On behalf of the University of Michigan Center for Disability Health and Wellness, welcome and good afternoon. Thank you for joining us for Disability Healthcare, a Native American Lens. This activity was developed in conjunction with the Advancing Health Equity for Adults with Disabilities from Diverse Communities Rehabilitation Research and Training Center. It is supported by a grant from the National Institute on Disability, Independent Living, and Rehabilitation Research. We hope this discussion will help us better understand the unique healthcare experiences of Native Americans, American Indians, and Indigenous peoples to better address disparities among individuals living with disability. Please be patient, as many of us are new learners. We welcome your guidance and teaching and cultural humility and spiritual awareness. The University of Michigan is located on the traditional territory of the Anishinaabe people. In 1817, the Ojibwe, Ottawa, and Potawatomi nations made the largest single land transfer to the University of Michigan. This was offered ceremonially as a gift through the treaty at the foot of the rapids so that their children could be educated. Through these words of acknowledgement, their contemporary and ancestral ties to the land and their contributions to the university are renewed and reaffirmed. We also acknowledge those joining virtually from their homelands and representing their nations. We have a reference here for those who would like to learn more. Thank you for your patience with that. So today we are so pleased to have a wonderful group of individuals representing tribes and nations from across America. Our moderator for the day is Melissa Buffalo. Ms. Buffalo is an enrolled member of the Meskwaki Nation in Iowa and Dakota from the Crow Creek and Lower Brule Sioux tribes. She received her undergraduate degree in child psychology from the University of Minnesota, Twin Cities, and earned a Master of Science degree in Human Development from South Dakota State University. Melissa has over 15 years of experience working in the public health sector in a variety of different roles. She brings a wealth of knowledge to the American Indian Cancer Foundation. As the CEO, Melissa is committed to working with and for tribal nations and urban and rural tribal communities with opportunities to heal emotionally, historically, spiritually, and physically from the inequities of cancer. Her responsibilities as the CEO of the American Indian Cancer Foundation include the overall direction and implementation of a strategic vision to improve Indigenous cancer outcomes nationally. Before Melissa gets started, I would like to remind individuals of the center's work. We work to develop and apply innovative research, clinical and educational strategies to address those inequities in healthcare access, quality, and outcomes that are experienced by those who have disabilities that are around physical, sensory, or developmental and cognitive disabilities. So, Melissa, I will turn it over to you at this point if you would like to share a little information about Native Americans and disability in America.
Yeah, Thank you for that introduction. Before we get into the data, I also would like to do a land acknowledgement just to honor the land that we're on, especially in light of Native American Heritage Month. The American Indian Cancer Foundation is located on the traditional homelands of the Dakota people in Bede, Otahe, Otunwe, Minnesota, or present-day Minneapolis. We acknowledge the Dakota people's continuous contributions, past, present, and future, to our world, and I want to give thanks to our Earth relatives for its generosity of life. As we begin this important conversation, I would like to take a moment to respectfully acknowledge that we are gathering here today to honor the resilience, wisdom, and strength of our relatives and our ancestors. We hold immense gratitude for the traditions and voices that continue to guide us forward. November is a time dedicated to the rich heritage, resilience, and contributions of our tribal communities across the United States. Native American Heritage Month allows us to reflect on history, amplify Indigenous voices, and highlight the unique experiences that shape Native identities today. When asked to, participate in this panel, was a little nervous because the work we do, as mentioned, is more around understanding the cancer disparities. But, I think we can kind of look at similarities when we look at, cancer disparities or disabilities disparities. So how can we connect and understand that both these groups highlight, right, that broader impact of healthcare inequities to the overall health and well-being. We understand that both these stem from systemic factors like limited healthcare access, socioeconomic challenges, cultural barriers, and historical trauma, which again, not only affect the health outcome of our people, but also the quality of life. So with that, if you want to share the slides again, I can start there with the data.
Melissa, would you mind? I think we should go back and introduce all of our panelists. And I'm sorry that the data slide was put up first.
That is okay. Yes. Give me 1 second. So again, our 3 amazing panelists who are here to speak with us today. I will first introduce Liv Akkerman-Byram. Hope I said that correct. Is from the Little Shell tribe of Chippewa and has an undergraduate degree from the University of Maryland. She is currently a second-year law student at the University of Michigan, specifically focused on Indian law and cultural practice. She is, in her limited free time, a registered Indian artisan for beading and leatherwork, and is a proud mother to her 12-year-old son, Henry. We also have with us today Dr. Mark Standing Eagle Baez. He is a Coahuiltecan member and a Mohawk and Pawnee descendant. Dr. Mark Standing Eagle Baez, I apologize, is the president-elect of the Society of Indian Psychologists and an assistant professor at Bemidji State University, is a licensed psychologist with a small private practice. He holds a PhD in general psychology and 2 master's degree, counseling, and 1 in school psychology. With over 15 years of experience in mental health and wellness and impactful research among Indigenous people across the lifespan, has inspired significant change in the field of Indigenous populations and the importance of incorporating traditional Indigenous methods and understanding the crucialness to address the mental health needs of marginalized Indigenous communities effectively. Thus, weaving in traditional methodologies is vital in working with marginalized populations across Indian country. He has developed a culturally responsive approach called the Sweetgrass Method, which focuses on weaving the best evidence-based practices and the best Indigenous strengths-based approach for the client served. He has also advocated for cultural strengths-based approaches to Indigenous people in hopes to change community-based approaches among American Indian, Alaska Native peoples by weaving culture, traditional methods, and Western approaches to improve Indigenous well-being. Lastly, I want to welcome Dr. Vicki Lomé. is Danae Navajo, Danae Navajo psychologist in Arizona, and focuses her clinical practice on developing and interweaving culturally appropriate methods into assessment, testing, and individual psychotherapy. For over 2 decades, she has worked with tribal communities in the Southwest United States and maintains strong ties to her tribal homelands and traditions. The guiding principles and values of her Dene identity continue to inform and guide her personally and professionally. Dr. Lomé co-edited the book Understanding Indigenous Perspectives, Hallucinations, Visions, and Dreams, and also co-authored chapters about multicultural neurohabilitation and neuropsychology. Again, welcome all of you, and thank you for bringing your energy and your expertise to this discussion. I think now we're safe to move on to the data. Data from the Centers for Disease Control and Prevention found that 30% of American Indian or Alaska Native adults have a disability, which is the highest rate of disability of any ethnicity. You know, essentially seeing that as 1 in 3, I think provides shock value. As we look at African American is 25%, white is 20%, Native Hawaiian Pacific Islander is 16%, as well as Hispanic. And then our Asian population is 10% with disabilities. Next slide. Again, the U.S. Census Bureau's current population survey with a combined 2016 to 2018 average found that younger American Indian and Alaska Natives were more likely to have a disability, which is about 16% than the overall population in the United States, which was 12%. Among our relatives who are 55 and older, 34% had a disability compared with 23% for the overall population in the same age range. Next slide, please. This one just looks at the life expectancy at birth, again, by Hispanic origin and race, you know, across the United States from 2019 to 2021, you know, highlighting again, American Indians have the, you know, lowest death rate at age 65, which immensely fell, I believe, in the last 10 years. I also want to say that life expectancy of 65 years has not been seen in the United States since the 1940s. And so again, looking at these inequities and disparities and how we look at this from that lens of disability and being able to discuss that here today. Next slide. This last slide, again, just looking at factors that are associated with greater risk of disability in a sample of American Indian Alaska Native individuals: increased age, female, lower educational attainment, lower household income, unmarried, not in the labor force, and residing in a metropolitan area. So I'm excited to bring this first question and have a discussion from all of our panelists. The first question, now I lost it. Oh, okay. How does the Native American community, you know, essentially view or feel about disability? And I will let any of you go, or I can also pick names. Dr. Lomé, do you want to start?
Yeah, I can start. Hopefully everyone can hear me. I'm Dr. Vicky Lomé. I am Dene from Arizona, and I am currently in Central Arizona on the traditional homelands of the O'odham and the Peepash communities. So for this question, you know, how does Native American communities feel or view disability? And I think it can depend on the community and the tribe. There are many tribes who don't view disability as something that someone can't do or are not able to do. I think a lot of communities view people as an individual and based on what they can contribute to the family and to the community, and what, you know, however their talents, however their abilities, and whatever capacity that they can, and how they can, use that for their family or for communities, I think is how a lot of tribal communities view individuals. I think there's also sometimes, again, depending on tribes, more culturally specific perspectives where sometimes certain abilities are viewed as perhaps a gift or maybe even a special ability, or that has a really specific cultural significance, not necessarily viewed as a disability, but more like a special ability. And then I think also, so there's different lenses through which I think communities view what we term as disability. Nowadays, there's also from the perspective of like education and school, where there has to be something identified to receive accommodations or support services. And then also, for myself working in a health clinic, there is the process of like formal diagnosis of certain certain issues. And then sometimes people acquire certain disabilities either through the course of maybe injury or, I work with a lot of folks who have experienced stroke or other health illness or injuries or conditions that make the diagnosis of a disability more likely. And then, so for me, having to be in that position of being able to, I guess, assign or give a diagnosis that actually will have implications for how this person can receive support and additional resources. So I think it's like a multifaceted lens that communities view disability. Right. I guess I'll just call on one of the other panelists, Liv or Dr. Baez.
Sure. Thank you so much. That was a great answer, Dr. LeMay. I would have to agree that, when we're discussing Native issues, something really important to keep in mind is the fact that prior to the Pan-American Indian movement, we really were kind of separate nations that did have contact with one another. But if you ask an Indian group, how do they handle something, you'll probably get as many answers as there are tribes in the United States. And so I've certainly seen that in my communication with other disabled Indians around the country from different areas. And I think, for me, there is a huge intersection between physical and mental disability. And a lot of times, especially in our community, they do go hand in hand. The mental toll that some of the numbers that Dr. Buffalo had shown, that affects us. And of course, we're going to, each generation, have to deal with the sort of the fallout from those numbers. And what was really disappointing was to see our numbers going down. That's certainly a trend that I think in our communities, we feel it and we notice it. And I guess I would just finally say, I think something unique about the Pan-Indian movement as a whole is really our use of the word medicine and how we sort of conflate traditional medicine for physical ailments, things like that, with medicine, such as spending time with people in your tribe, being in your community, participating in cultural events. Those in our community are considered medicine as well, sort of for the soul. So I love the Indian holistic approach to wellness. But unfortunately, due to a lot of cultural problems in our communities, we are struggling in a different way than other minorities in the United States.
Seego Chumanam, Tapilam, Coahuiltecan, Mark Standing Eagle Baez. Hello, good afternoon, everyone. From the people of the earth, Tapilam, literally translated, Mission Indians in Texas. I would tend to think about, how do our people view and or feel about disabilities just working across Indian country. Adding to what Liv and Vicky had stated, but also include balance. For some tribes, they may see these disabilities as a result of being out of balance. However, the goal is to achieve the state of balance and wellness. And it's essential to know the latter part of that, not just they're out of balance, but how do we bring the balance and wellness to that individual, as well as welcoming. So some Indigenous communities welcome individuals as people first, and are reluctant to identify them as anything different or impaired or disabled. For many tribes, there is no word for disability. These gifts, as Vicky had mentioned, it's not disabled, but differently able. So we're not viewed, or we do not view it that way. So it's not that we don't connect or understand. It's our understanding of how we see our world and how we connect to this earth, bringing that balance in the realm.
Thank you. I think you all touched on similarities, but beautiful differences that help to shed light on how so many of our communities, right, are unique and distinct, and they all have different traditions and cultures and how we view such things as disability. And, Dr. Baez talking about there's no word for disability. I love that our languages don't have words and understanding like that. The same with cancer. That word doesn't exist in our language. So again, thank you for that, for providing insight there. Before we go on to the next question with our panelists that I have, I just wanted to see if there's any questions from our audience. I know I'm not seeing any in the Q&A, but if anyone wants to enter anything in the chat.
If anyone would like to speak, unmute you and you can direct your question to the panelists. We do. Oh,
I was just gonna say, it looks like someone does have a question, if that's okay.
absolutely. So Jody, let's see. I hope to ask a question regarding the disparity between other First Nations groups that you may have researched. So let's see, Jody, I will allow you to ask that question directly.
Jody, you should be allowed to unmute now and go ahead and ask your question.
Was the question something about conducting the same research in the First Nations?
Regarding the disparity between other First Nations groups that you may have researched. Excuse me.
I can only speak to a couple of the tribes and also a newly published book titled Indigenous Disability Studies, and it's a compilation of working with Indigenous populations in the United States and in Canada. I personally did not work with each communities in Canada, but I have been in Canada, in Calgary and north of Calgary. A lot of some of the examples that I gave are very similar, where there is not a word for disability, and that we see the individuals as people first. And I believe Dr. Lomé had alluded to that individuals with disabilities are seen as individuals that are unique and come with a perspective of individuals that have gifts versus an individual that's seen as a person with a disability. So one of those things that I have seen is the balance seems to be very similar. The reason why an individual may be diagnosed with a disability is because there must be some imbalance happening. Is very similar. The welcoming, again, is we see our people as people first versus identifying them as an impaired or disabled person. Again, is a lot of parallels, very, very, very similar.
Thank you, Dr. Baez. I'm going to go to Dr. McKee right now. He is co-director for the Center for Disability Health and Wellness, for those of you that are familiar. Dr. McKee is asked, are there strategies that we can learn from your tribes/communities on how to better care for our patients with disabilities? And I will add, prior to the answer here, that Dr. Baez is going to get more in-depth about the sweetgrass method, and I think that will provide some insight to this question. However, would any panelists like to share any strategies to better care for patients with disabilities?
Yeah, I'd be happy to answer that one. I believe from what I've seen in my community and other communities that the strategy that is most different from Western medicine, I think, really is that holistic view of a whole person. So even if somebody is struggling with something physical or something visible, I've found in my community, when we talk about health, when we talk again of medicine, we're talking about your spiritual life, your relationships with other people. So I would say, you know, something that I don't see in Western medicine as a person that's treated in Western medicine for my disabilities, it really seems very disconnected. You have a specific doctor for every little part, but there seems to be a lack of looking at the person as a whole. And so I think that that is something that Indigenous communities do well, that Western medicine would be good to try and imitate in some way.
Yeah, I was going to add that this, I think it's more commonly known like as holistic medicine, but in Native communities, you know, it's just, that's just kind of the wellness of the overall wellness for a person. And I think integrating not only, again, just the physical aspect of it, but also, you know, the social, emotional, spiritual, cultural aspects of the whole person. And I think in some tribal clinics, they really strive to include all of that. So it's not just the physical medical aspect of it, but more of, you know, including family, including, you know, the community, their social connections, but also, and some tribal clinics have traditional healers and traditional practitioners on staff to address that part of the person's whole health. So I think, you know, kind of looking at it from the whole person, not just whatever the medical diagnosis or official disability diagnosis is. So, yeah.
I would also add, just listening to both Liv and Dr. Lomé, when I hear that, just as an Indigenous person, is honoring who I am and where I come from. Traditional approaches incorporating cultural responsivity is a huge component, specifically when we're speaking about agencies that are non-native, and we're sharing with you all these steps, and you're thinking, how the heck am I going to take those steps? I'm not even native. So a lot of what I've seen across Indian country is professionals stop their services where they don't want to infringe or maybe offend or be insensitive, so they will not offer but asking permission is the first step, at least building that relationship. And I'll get into that a little bit with the sweetgrass method. And that was one of the intentions, is incorporating the Western base of what most of you, all of us, have jumped through, the Western schools and instruments that we have to use. But when we went back to our reservations, it's like, this doesn't work here. So how can I do what I need to do to make sure my community is being helped? So we would take those instruments, those methodologies, those Western methodologies, and we would tailor them to our people's way of learning for the people. And those are essential steps where we can start seeing positive change versus, I don't know that, so I would choose not to step in that realm. But weaving those together is essential when we're really looking at positive outcomes.
All right. Thank you all. We have a number of questions in the chat. However, I think that I'd like to go to question number 2, and let's address that. And then we'll have, I think, a decent amount of time to hopefully get through all the questions in the chat and have a great discussion.
Thank you, India. And thank you all for the questions. Hopefully we can get to them. Our second question, we wanted to talk with our panelist. How do Native American communities, our tribal nations, experience disability healthcare, in their homelands, on their homelands, or even, I guess, too, in the urban communities? So why, Liv, do you want to start us off?
Sure. So I can speak for the urban communities. I'm not somebody that has received healthcare from IHS or on any of Indian country. So I can speak kind of just for the urban side of things. But tying into last question, I think one of the bigger issues that I'm seeing is a lack of addressing the person as a whole. And like Dr. LeMay had said about, holistic doctors, for me personally, with the specific disabilities that I have, it's generally like specialist after specialist after specialist without a whole lot of interconnection. And so I would say that's a big issue for kind of city natives. But I am not in a position to speak about IHS or medical care on Indian land.
Dr. Baez, do you want to go next?
Sure. And I'm hoping that I'm not taking this position from a negative standpoint, but when I just heard the question, what are some of the experiences? What jumps out is the lack of diversity. I mean, if we're having, or we've been put on this label of an individual with a disability, is the serious lack of diversity in understanding who we are as a person, as an Indigenous person, how we can truly help. So the experiences coming from clients is the lack of diversity. Also, the communication barriers that are happening that seem to continue to perpetuate areas where we're not receiving what we should be receiving for our experiences for this care of health. Not to mention discrimination that happens continually, in addition to cultural barriers. So these are, I'm just naming 4 that continue to lay into experiences that our community members continue to face. And if we were to face this daily as practitioners, as professionals, would you go back? I don't think so. But some may have this impression, if they don't want to come back, maybe they don't want help or they don't need help. That's not the case. And if we can really look at these steps and weaving in more culturally responsive approaches that looks at the diversity, even the staff that we may have, the discrimination and or the cultural barriers, we really are looking at some amazing steps or ingredients for success for our people.
Thank you, Dr. Baez. I think, again, we could keep going, right? And understanding too that Indian Health Service is one of the lowest funded agencies within our government, and that it's definitely underfunded. So Dr. Lomay would love to hear from you as well.
Yeah, so I have worked in the Indian Health Service system and have some experience with that. I also work in a tribal health clinic, an outpatient clinic. So I see the way that I see how disability is experienced is kind of across the spectrum. I mainly see folks individually after they have been coping with this, their disability or their chronic health illness or the injury, not in the acute phase, like not the emergency, right after it happened, but usually after the long term after, sometimes months, sometimes years. So I see kind of their real world day-to-day experiences of how they're functioning with the disability. So like, for example, if there was an acquired injury, like let's say traumatic brain injury, or a stroke, they've long passed maybe the rehabilitation phase or the hospitalization phase. Now they're back with their families and trying to figure out how to get services in the community. So I see that experience and try to provide, resources and support as best as I can. But it is true, there is definitely funding limitations. If there were unlimited funds, there could be a lot of things that I could recommend, but we try to do the best that we can with the resources that we do have, which I think is fairly common across a lot of places where people receive their services, either clinics or hospitals. For a lot of Native, Indigenous folks across the U.S., it is almost often through either tribal health clinics or Indian Health Service related clinics. So I think trying to find some ways to work with them. However, what I also see is that there is, and I think this is what Dr. Baez had alluded to also, is that there is definitely underneath all this is definitely a really complex web of kind of just an intersection of history, health issues, like just historical things that have also interplay into this as well. So, for example, just like looking at social determinants of health, not only how do they access their health care, how easily can they access their health care, who is providing their health care, how is it being provided? So some of these questions definitely factor into how different communities experience their own health care and how, disability resources and support services are available. The other part that I also see is how from like a mental health perspective of how there is that intersection of other comorbid diagnoses, like for example, the effects of trauma, and the effects of other mood issues such as maybe like depression or other things like that. So there's definitely sometimes it's not just like one particular diagnosis going on or one particular disability. Sometimes there are other things going on as well. And I think that's where being able for clinics to be able to kind of integrate the whole, not only just their physical healthcare, the medical healthcare, but trying to integrate all these other services that can be helpful for the person, but also being understanding and being aware of how that is really, really culturally important to a lot of tribal community members.
I noticed in the group chat, there was just some talk real quick about Echo, the Native American superhero. I just wanted to plug. It's awesome. Really great. I have a kid. So being able to see not just a Native American character, but a disabled Native American character. And she really embodies what you've been talking about being differently abled, but having those gifts. So while she is deaf, she has the ability to basically do anything that she sees happen. So if you have kids, it's just great representation. The show's great too.
I think it's a great segue, Liv, because I was just going to say what Dr. LeMay was just sharing, and I just wanted to point out that if we were to have an Indigenous practitioner at every facility, that we wouldn't have any communication barriers. And the clarity on the communication barriers, what I wanted to point out was that communication can make it difficult for our people to access healthcare, of even understanding what was given to us in medical terms. We don't have that understanding, or we may not remember that jargon. But having individuals like these superheroes like Dr. LeMay, if we were to have a Dr. LeMay everywhere, or Liv everywhere, or myself everywhere, of course we would have that opportunity to provide amazing experiences for our people that are there for healing, and having that that Indigenous person or clinician really helps with the process, through the process of an individual that has been identified with a particular disability, to have that understanding at least a lot better.
Melissa, did you want to comment on this question?
Nope, if you have something, go for it.
Okay, I was just going to read one of the questions here in the Q&A. This is from Dr. Diane Harper. NIH, National Institutes for Health, has calls for funding for research that partners with the Native Americans and calls for those with disabilities per their definition of disability. As a researcher, how do I find a group centered in Native American and disability to understand more about their cervical cancer screenings? And I will add that Dr. Harper is a world-renowned expert in this field of cancer screenings for women who have disabilities. And she has been a partner with the center. And I think she is very excited to learn about this intersection.
I'll just go first briefly. I'm not sure if there's a group just set aside just for that across Indian country, where we have elders that you could just sit down with and start talking about cervical cancer screening. It goes back to building the relationships that we have, that is honoring of our people and honoring our experiences, to sit down and to hear from the group of Indigenous people. The first question was about how do our people feel about disability, and Dr. LeMay started out by saying that there's many different perspectives. It's not just one tribe. So to say this is how you do it is not the correct approach, because there's many perspectives on disability, and it varies from different tribes and nations. But to begin with the dialogue is where it starts, and to have the initial steps of honoring, as I mentioned, truly honoring the people and their experiences, is setting you at a place where you're not better than them. You don't know everything. They don't know anything. You're a doctor. They're not. You're right. They're wrong. So coming again down to a safe space, honoring one another, and exchanging that dialogue is the essential first step. And I'll share that a little bit when I talk about the sweetgrass. But speaking to the tribal councils, some of the behavioral health, some of the traditional practitioners would be a place where I would go. I'm Native. I go into another tribe. I don't know anyone. So I have to start speaking with leaders, and even when I'm addressing leaders, there's certain protocols. So there are very sensitive steps. It's not, hey, this is who I am. I'm here to save you. I'm here to give you the answers. It's again, we want to know who you are, where you come from. What's historical is we've been lied to for centuries. So why would we trust you? So it begins with a relationship. It begins with taking those first steps and asking permission. Not, I'm just going to tell you. So it may sound very simplistic, but quite a few people miss the boat on that. They come and they press their own agenda. And when it doesn't hit, it's usually the tribe's not ready for it, or I guess they don't want the help. But it's not that at all. It's really meeting with them and honoring that space and one another for that initial dialogue to build that relationship. You're not selling anything. You're not there for buy-in, because we don't want to buy anything. What we want is we want to build partnerships. That's who we are as people. We're not there just to hear because we've heard it before. We really gravitate towards genuine partnerships and relationships. So I'm not sure if that helps, but at least gives those initial steps of beginning that dialogue.
Thank you, Dr. Baez. It seems like I'm hearing, and I will say that Dr. Baez and I had a lengthy conversation last week, is that relationship and honoring individuals and tribes and communities and respect is the starting point to help address access, healthcare equity, and to make that connection and interest in partnering for research in health and disability. Do any panelists want to make final comments before we move into the sweetgrass method?
I just want to, I guess, kind of comment real quick. I think this topic that we are discussing today, we can definitely have many, many, many more conversations and definitely go into a lot more detail into some of these topics that we just barely touched upon. So this is definitely, I think, a good start. So I'm very appreciative that, we have the opportunity to share some of this information and get the conversation started. And also for participants to be able to ask questions, because I think that can definitely be a springboard for future conversations that maybe we can actually talk a little bit more about some of the questions that in the chat that we can't get to right this minute, but I think definitely we can save those and maybe at some point continue to have these conversations, because I think that's definitely important, is starting the conversation. And then, like Dr. Baez was saying, of starting to understand and develop relationships so that we can, work towards better healthcare for our Native communities.
Yes, well said, Dr. LeMay. As we wrap up this evening, but that's at 4:30, that is going to be part of the discussion. What is the next step? Because we have just gotten to the very, very tip of the iceberg. With that being said, we are going to move forward with Dr. Baez and speaking on the sweetgrass method.
I'm going to try to condense this 2-day workshop into 4 slides. So I will do my very best. So first of all, I wanted to just share with you what is sweetgrass and what is a sweetgrass method. In a nutshell, for the most part, sweetgrass is a sacred herb. And for some nations, it's used for prayer, for ceremonies, for honoring, for dances, like for individuals during their rite of passage. So it's used for sacred events, cleansing. Thus was the reason I chose this specifically, is working with clients. I knew that every client that I was working with was sacred. Now, as a psychologist, things that they were doing was not sacred, but I knew the Creator created them as sacred So I knew that I needed to approach them with respect and honoring their experiences and just approaching the dialogue, the therapy session, the intake or the assessment in a sacred manner. But this grew out of frustration. The sweetgrass method grew out of frustration due to barriers to services for our people, because I knew a lot of the Western methodologies were not working. And colleagues, non-Indigenous colleagues were saying, I guess they don't want the help. But that wasn't the case. Our people very much need the help. And what was being provided was not connecting. So in around like 2007 is when I just really started playing with how can I continue to incorporate our ways of knowing, our ways of being, our ways of understanding. So the sweetgrass is a self-motivated process for either prevention and or intervention for practitioners to use to begin a healthy dialogue with Indigenous people by incorporating the self-reflection, communication, and the continuation of culturally responsive tailored services. And I'll get to that diagram. And the diagram looks like the sweetgrass, and it opens up to each of the braids, so you can see that a little bit better. But essentially, the sweetgrass method combines the best of evidence-based practices, Western, with the very best of Indigenous strength-based approaches for our clients. So I know that there's a lot of instruments that I continue to use today that are Western, that were generated from a Western lens. A lot of the theory approaches, same thing. What I would do is utilize that and tailor it using the Indigenous strength-based approaches for the client. And so I was seeing a lot of successful outcomes when I would incorporate evidence-based practices along with Indigenous strength-based approaches for Indigenous populations. Okay, next slide, please. So this cultural framework, as I mentioned a little bit earlier, was something that I wanted to specifically tailor services that incorporated cultural responsive steps intentionally, that it wouldn't be left open to, well, I was culturally sensitive, I wasn't offending them. No, I was being responsive. I was responding in a way that my client would respond by knowing a little bit more about the individual's culture. So the introspection, that first strand, looks into our areas of strength and areas of need and or weaknesses of what we know and what we do not know. So when we come to working with a client with this cultural humility, we take these steps as equals and learning from one another, who I am, where I come from, and this is what I have to offer. And then meeting with our clients, who are you, where do you come from, and share some of your gifts. And I'm shying away from this cultural competency. I have several plaques that say I'm culturally competent. I'm Native myself, but I don't know everybody's culture, their ceremonies, their ways of living or understanding. The cultural humility really gives me a better understanding and grounding myself that I do not know everything. And for me to ask the client that I'm working with, how can I help them help themselves? And as I mentioned, the first strand, as you see woven into this picture on your left, that's a sweetgrass or in braids. But in that first strand is also weaving in Western and Indigenous methodologies for your clients. You know your material, you know your instruments better than anyone else, what would work. Also, how do we incorporate more cultural practices for our clients? The second strand in the sweetgrass is the communication, and how we communicate really determines how we move forward with the clients that we are serving. It's really, really essential to know that as practitioners, we know that strength-based approaches work best for healing. If not, this is the best approach for Indigenous people. So we have more opportunities for successful outcomes when we look at frameworks from a cultural lens. Thus, this this activity that we have today, at least providing the first steps, as Dr. LeMay had mentioned in this discussion. The vital work of Indigenous researchers is impacting, I believe, our people's healing. And when we look at the concepts, our stories as evidence, our ceremonies as evidence, and Indigenous ways of knowing as evidence, they match just as valuable as Western-based practices. I would love to say that again, because Western-based practices has always been, this is the standard, you only use this, and discounted our ceremonies, our Indigenous ways of knowing, our stories as evidence. So I wanted to make sure that I made that point, and using this technique and understanding by incorporating this sweetgrass, as I mentioned, is an herb that we use for ceremony, that we take these steps and and as a reminder of those that we're working with are sacred. Next slide, please. So I was trying to show this diagram as a braid when taking each of these strands apart. But there's no question that most Indigenous people know that most of society holds the monetary resources to help Indigenous people with disabilities. We have this understanding, and the majority of society consequently has the power to decide what services or resources will be continued to our people and what resources will be offered. That's huge. That's powerful. So as the person providing those services, you have the power to decide what services or resources will be continued. And I say that because the sweetgrass method forces you to have this cultural humility, to weave in the best practices that you know, but in addition to also weave in Indigenous methodologies. To effectively address this range of critical needs, it's important that we provide services that reflect best practices grounded in our awareness and or cultural awarenesses and or responses. But this technique, these steps, allows the client's cultural identities, values, environment to shape the understanding of presenting problems or even developing treatment goals or delivery interventions. So we can truly take a step on cultural responsivity by incorporating a more culturally appropriate steps for the clients that we're serving. Okay, next slide. And this last one here is just as a note that there are many Indigenous communities concerned with the seriousness of disabilities. There's no doubt about that. And even eager to advance effective, answers to this this area of concern that we're saying, or that we're calling disability. However, communities are also concerned about the perpetuation of colonizing, disordered focus, stigmatizing approaches to disabilities, and or social narratives related to learning essential steps. So again, I go back to, it's not that they don't want help, it's the approaches that are being served. If they don't like the food, they're not going to eat it. As I mentioned, our people are hungry for healing, are hungry for joy. Who isn't? But if we do not like what is being served, we won't eat it. So a recommendation would be get an Indigenous cook, add some of our own ingredients, and I guarantee you'll start seeing your clients come into your office and participating more when they know that the ingredients that are being provided or serviced or served are tailored for our people. But I'm not discounting the importance of Western medicine. So by bringing those together with the sweetgrass, and as a blade of grass, when it's stepped on, it eventually it bends back, is the flexibility of it. And that flexibility is a reminder for us as practitioners to be flexible. It's not just one cookie cutter approach, is that we're flexible to every person, every community, every tribe, every nation. And that's it. Thank you. I did,
Nice.
while there's some questions coming in, I did want just to add everything that Liv and Dr. LeMay has been sharing are steps and approaches woven into traditional methodologies incorporated into those services, whether they're from a traditional practitioner, holistic approaches. It's weaving that in for the client, and they may be different for every other client. So it's not, I guess we're going to have a traditional practitioner for every client, because we don't know if every client that we have utilizes or understands those steps. And I believe Melissa had mentioned it starts with asking permission. We don't come with our own agenda, even though we have so much to give for healing and we want to be there to help. You know, it takes that relationship of respect and honoring our people by asking our people.
We do have a question. Tanya Marie Sanchez has her hand raised, and we can allow you to speak if you'd like to address the group, Tanya.
So, can you hear me okay?
Yes.
Okay, I'm sorry. I have never joined one of these before. So it sounds like some of the key issues to, Native American healthcare and like other issues as we've been discussing in our class have mostly to do with infrastructure, like socially and like physically, with like funds and like resources and tools. Am I getting that correct with kind of like the back and forth and what the slides were just saying? That seems to be the key holdback, and just like a kind of a decolonization or like a non-Western dominance when dealing with Native American healthcare, just like being open to different indigenous groups and individuals asking for specific type of care for them personally. Is that like a correct understanding that I'm getting here?
Can you rephrase that? Can you, I think there was like multiple parts that I'm trying to.
I guess as a first timer on a panel like this and trying to understand some of the difficulties, it's on a social level and an infrastructure level, as far as like having resources and tools and having doctors or people in healthcare providing healthcare specifically to Native Americans within their scope or understanding or traditions of healthcare. Is that is the aim that you are all discussing as being the problem people need to work through to provide like adequate care?
Yeah, I think in some in way, yeah, of working with the different resources that are available to try to provide the most culturally appropriate way, or trying to work individually with the communities. Because again, what will work for one community may not be the exact same thing that might work for another community. So I think, again, having that idea of collaboration and communication, it while also understanding that there could be limitations.
Right. I
Yeah.
just think whenever I'm listening to this, I'm just trying to make sure too, for my future endeavors as a student at UMich, like I'm majoring in Native American studies or American culture, I want to make sure I'm using proper language to like effectively work, in whatever spectrum I work in, whether it's healthcare or like indigenous, I know like well-being on reservations or Like, I know I was just talking to Dr. Hughes, who is my professor right now, about tribal liaison, you know, to ensure that like the proper language is being used across not just healthcare, but needs of the community in general. And so like I'm hearing that the language and understanding different indigenous groups or communities like needs is really the goal. And I'm wondering like how in my day-to-day learning, like how to help inform other people about how important that is, if that's
I don't mind jumping in. Awesome that you're getting your degree. What a awesome subject. I would just like to point out that when we're talking about Indians in the United States, and when I use Indian, you were a little bit worried about phrasing. I use it as a term of art. The laws written about us, it's the Bureau of Indian Affairs. Most of the laws written about us do use that word, which is why it's my preference when I'm speaking of all of the indigenous people in the United States, because we have, I would say, since, sort of assimilation kind of been lumped together. But what's really important for me is that there are so many natives that have been removed. And me being of the age that I am, I'm from, descendants from people that had been removed. And so for me, growing up on the East Coast, I had no language for speaking with Indigenous people about what was going on with me. All of my healthcare where I'm from had been Western medicine. And as an Indian, there always did feel like there was something missing. But I think there really are sort of two camps of people that receive their care through IHS on Indian land. And then there is still that whole bucket of us that have kind of been diaspora around the United States and may not have community and may not have traditional healing methods available to them.
I really appreciate you indulging my question. It's very important to me as a descendant myself. My mom's still trying to get tribal status and things, but like, so that's been a tricky situation for her. But I just always want to make sure that I'm understanding and not taking up space that isn't mine or understanding the different needs of people. So I really appreciate this panel. Like I said, I've never joined one before, so I appreciate all of your input. Thank you.
Tanya, I also want to thank you. Being a first timer, I'm sure it could be incredibly nerve-wracking and then asking a question. So props to you. One of the things that you were saying a couple of times really reminded me of the cultural humility is what I don't know, but that hunger to find out so I don't make those mistakes is essential when we are making diagnoses or when we're working with our clients. To find out as much as we can and to have this dialogue of understanding one another and how each other can help one another, the gifts that they bring, what has been working for them. And again, I just go back to it's not just for us as clinicians, professionals coming with our own agenda, but when working with our people, indigenous populations, there's so much specifically with disabilities. As I mentioned, there's no word for disability. So how do we begin this dialogue? Maybe looking at words that are more sensitive versus re-traumatizing. So our people don't want to go back. And it's not because of anything of not wanting to be healed or to feel better. It has, again, a lot to do with how we're being treated, some of the words that are being used, and the discomfort of even being in a clinic or in that environment. So at least having those steps of creating a more healthier partnership by understanding who they are, where they come from, and laying those foundations to build a healthy connection and relationship, again, is essential for those steps to go. The last step, if you didn't remember in the sweetgrass, what seems to fall off with many organizations is the continuity, the continuation of those services. And I say a lot of these programs across the United States, they have a honeymoon phase where some of them will provide amazing services to clients. and then seem to either burn out or just kind of fizzle out. And I'm taking the feedback from the clients who are saying they don't even call me, they don't even follow up with me. I don't feel like I am anyone else other than just a number. So that last strand in the sweetgrass is that obligation that we have as professionals to provide ongoing the continuity of those services, not just providing services, but good services, services that they should be receiving. And that's something that is really, really important to remember.
Thank you, Dr. Baez. We have so many questions. I do want to get to some of these, and I'm picking these at random. My late mother-in-law was disabled with arthritis of the spine, and it seemed like there was an unsaid stoicism that was part of her persona, and as a result, she suffered more than she should have. What can we do to encourage people to fight harder for the support they are entitled to? Melissa, I know you're moderator, but I'm thinking as the CEO for the American Indian Cancer Foundation that you may have some thoughts on that. Don't mean to put you on the spot.
No, I agree with that stoicism, right? I think it's also understanding sometimes for people that sense of, this healthcare through IHS is free. So they, might tend to hesitate on kind of what their needs and advocating for them, but also understanding, trying to get an appointment takes months, trying to get a referral out takes months. Hearing some of the stories here and thinking about connections to my family. I had a family member whose son needed an assessment for autism, and it took over 2 years. And I cannot imagine, as a mother who has a child with ADHD and is on the spectrum, who doesn't as an adult now need to rely on Indian Health Service for my healthcare, but knowing that it's there is, good to know. But those are everyday experiences that our people face. So I think when we think about what those roles of Indian Health Service, again, anywhere from policy change to understanding the importance role that advocating and feeling that your voice matters and that you know your body best. And even as that daughter, how can she serve as a voice in attending some of those doctor's appointments and speaking on behalf of her mother is some of the things that come to mind.
Thank you. Let's try to squeeze in one more. Dr. Banks, you have your hand raised. Would you like to be unmuted to speak?
Good afternoon. Thank you so much for this panel and this information. I had put my question in the chat and I stepped away, but I wanted to ask about the high rates at which schools are suspending and expelling girls of color with disabilities, and especially Native American or Indian girls with disabilities. And school is a place where they can identify issues that students are facing and should be in a position to connect them with resources. And I wondered if you could address this and see how we might better help schools to get connected with providers who are using the sweetgrass method or other appropriate methods for these students instead of suspending and expelling them.
Just briefly, I'll just jump in real quick, and please feel free to add. I still work with schools across Indian country, and that seems to be a problem. I do know that even students with disabilities can be expelled depending on what had happened. However, a change of placement would be something that we always have in place, not just you're kicked out, that's it. So the school still has an obligation to provide services. With expulsions, it's a little different, but I've seen so many suspensions that they still have to have a change of placement and provide these services. These schools, the BIE and schools across the United States get some big dollars for IDEA services for students that have been identified with disabilities. The Sweetgrass method is free. You just type it in. You can look at those steps and approaches for schools. If you type in, I think it's a Sweetgrass method to bullying, which so many schools are looking at how to take these steps to have a better relationship with parents versus the only time I call a parent is when there's something wrong with your son or your daughter. And when that happens, there's a really poor relationship that is starting, and some of our parents don't want to come to the school because they feel that they don't like them, they don't like my child, it's us against them. There's no connection there. So the Sweetgrass intentionally braids them together for the sake of the child. Now we're adults and we're professionals. We should be professional, that we take those steps in really braiding healthy relationships for those students specifically that are being either kicked out of school, suspended. And there's also a time limit on suspension. According to the laws, there's a certain amount of time. They can't be suspended for the year. There has to be a certain amount of time, but there has to be documented meetings that follow these laws that are in place. That's why they're put in place, because some institutions would suspend them for the year. But these IDEA, Individuals with Disabilities Act law, is set in place specifically for those reasons. But the schools are more than welcome to download the Sweetgrass method, again, to take these steps to better curb these initial reactions to suspend. Again, I don't know what the reason is, but I do agree that students need to be in school and not at home. But again, it's what's going on, what caused that child to do what they did. It's not, more likely than not, and Dr. Lomé can attest to this, it's not a random thing that just happened in English class. There's a lot of factors layered in there. So the more that we at least weave in more cultural opportunities to respect and honor one another, we can really begin to work together, the parents and the school, for the child. When we do that, it's an amazing combination for success, because the child knows you're talking to my auntie, you're talking to my uncle, you're talking to my mom, my dad. And I'll just say this, I won't say what school, but I remember I saw one of the students and I just said, hey, I was talking to your mom. And he looked at me like, what the heck? You know my mom? And I saw him at a flea market in Gallup. And soon as that student knew that we were communicating, I said, hey, look, we're on the same team. We're two coaches. We want to make sure that you as a player make a touchdown, that you score. So we need to communicate. And so when we started doing this, we really started seeing some amazing changes. It wasn't at first, but knowing when we had this dialogue, working together in a healthy way, we started to see some amazing changes.
Thank you.
I think this conversation could definitely keep going, especially now that we got some of the questions from the audience. And so before I hand it back to India to talk about some of the next steps from the center, I just again want to thank our panelists for bringing your expertise, your experience, and just, the work that you do for and in Indian country. I know I appreciate it, as well as the clients that you all serve and the community members that benefit from your work and education. Again, I just want to add this last thing, as we leave here today and, wanting all of us to remember that building a more inclusive and equitable world for our Indigenous people with Indigenous disabilities is a shared responsibility. And I think we talked a little bit about that today and, really hearing, the importance of balance and accommodations. And again, what does that culturally responsive healthcare look like and how we can amplify those voices in your own communities and how we can use this conversation as a call to action. So again, Kitabi, Wopira, thank you. And also for attendees for listening in. With that, I will hand it back to India.
Thank you, Melissa. I would like, I know it's 4:25. So I would like to say thank you, Melissa, for moderating. Thank you, panelists, just in case people step off. I will say that please reach out to the Center for Disability Health and Wellness if you would like to continue this conversation, because this is the beginning. You can contact me, you can contact Andy. Our website is online. Now, I'd like to go back to the panelists because we need to continue this conversation. And that was the intent when we joined together to make this happen. So Melissa, would you all maybe share your thoughts about next steps? I know Dr. Lomé mentioned that this is a complex web, and we're seeking your guidance so that we can help detangle this web. And what are some next steps for us as supporting the community, supporting the clinicians, and how should we shape that? So anyone can just jump in.
I can start off. Well, I thank you all very much for attending and for listening and for your questions. And I think that's actually probably where the next steps would be, is to continue to have conversations, to continue to ask questions. And I think hopefully we can have the opportunity to try to answer a lot of these questions, because I think that's where the information can be valuable, is when you ask questions and then you get answers. I think for myself and maybe for Dr. Baez and maybe for some of our other panelists and our moderator, that this is the work and our kind of our day-to-day experience. This is kind of the life that we're living and what we're working. So sometimes it seems like to us maybe some things may appear just kind of obvious to us, but when we are a part of larger groups and kind of have more of a larger conversation, then we realize that, there are definitely questions and perhaps some details that we can provide more about. So I think definitely continuing conversations, continuing to ask questions, and continuing to have the space for that.
I don't have much to add besides, as a student here, it would be really great to kind of see some of this in action at UHS. That seems like a small step that we can, Michigan has more and more Indian students coming all the time. They're heavily recruiting for Indian students to come here because of their programs. So I think if there's some way we can kind of bridge the gap between talking about this and then being able to put some of these into practice for students going through the university right now would be really helpful.
That's great. Just what Dr. Lomé and Liv were saying is these are the steps, and then this is important to do something, to put it into action. And it won't happen until we do that. We can keep reading about it, we can keep thinking about it, but never actually apply it would be something that we would definitely miss. And how we do this, it takes those conversations. Contrary to popular belief, just being Native, I was told to go work at a tribe because I was Native. And I'm like, why are you asking me? Well, you're Native, but I'm not that tribe. Again, I didn't know their ways. I didn't know their customs. So for all of the guests that are here, we have to be in a position that we are culturally humble, that we're coming to someone else's land, that we do ask permission, that we do approach with humility, with respect, with honor. We do this too. So it's not something that we're saying, well, we could do it, but you know, we can kind of get away with it. This is how we need to take those steps. So in action is taking what we learn, what we know, what we understand by reading. And that's one of the things that I would encourage you is to look up as much as you can about partnering, about building relationships that are culturally sensitive, culturally appropriate, and culturally relevant. We don't want to apply something that was used in the 70s. Not all of us live in teepees. So at least having an understanding is the first step. And that what that would say to me is that you honor me as a person because you're trying to find out about me as a person and my family and my community versus I worked with the Mohawks. This is how it's going to be. And I'm going to use this for the Dene people. And that's how it's going to be. If it doesn't work, it's the Dene people. But no, how do we be just as flexible to work with them is just by knowing, and how we're going to do this is by talking about it and then incorporating it. And how do we do that would be a good way to have a conversation on how it looks like and what steps do we need to take.
Thank you, Dr. Baez. Melissa, did you have any last thoughts as far as next steps and what we need to do moving forward?
I think that was beautiful what all three of them said, and just want to agree with all of it and emphasize that call to action.
We will be sending out an evaluation. On that evaluation, we will add just a little box indicating whether or not you would like to receive future information, be involved in activities, join us in partnering to address disabilities in the Native American community. And thank you again to the panelists and Melissa for your input, information, and your time. And I will be reaching out to see if we can continue to work together in the near future. Again, I thank everyone for a wonderful conversation, and I'm excited to continue soon. Thank you.
Thank you, miigwech.